It hasn't let me in yet.
Okay. Other people,
Let's see.
other, okay, all right. Okay, bye-bye.
Dr. Wifo, I apologize.
Hi
I
there.
was trying to get Kobna to start the meeting, so I had to get Ellen to do it because I couldn't reach Kobna. I think he's in clinic.
All right.
So sorry for the delay. Rex, you guys, sorry for the delay.
Okay, we're on here.
Don't worry.
I had my camera on a minute ago. Can you see me? Can you hear me? Can you see me?
I can hear you. Let's see if I can see you. Wifo, I think your camera is off.
Yeah, I had it on just a few moments ago. Let me see what's up with that.
No, your camera is coming up as off.
Let's see. Right. Close out of this.
Your camera is still off. Otherwise, so you can share.
Got it now.
Yes, we see you now. So you can
Splendid.
share screen.
All right, hi everybody. So got to share screens, I believe. Share screen. Screen 2. Is that sharing?
Yes, Wifo, we see your screen.
Splendid. Next step, put something in
Full screen. Put it in full screen, right?
screen and then slide show, right? Slide show mode. Right here. All right. Give subtitles a try. I don't know what that is about. I'll do it. Okie doke. Are we on fully? Uh-oh. Can everybody hear me?
Yes, Wifo, we can see it and hear it.
Okay. Is that the sidebar showing for everybody? The subtitle thing, that's almost like
I'm getting everything. I'm not gonna put it on.
closed captioning.
Yeah, it's a full screen now, so we're good.
Okay, great. All right, so good afternoon again, everybody. If we may ask, how many we got on today? Hi, Theo.
Wifo, say that again. Sorry, I'm multitasking
Theo,
here. Yeah, you can start. I think we can start.
size today?
How many what?
How many participants?
Oh. We have 14 now. I'll check with the anesthesia folks. I know Audrey, Dr. Tinyabua had said they would join as well, but I guess the delay, some must have logged on and logged out. So I'll text her. Okay, but I think we can start.
Wonderful. All right. So today's topic is fundamentals of acidosis. And this lecture has been a long time coming, right, Theo?
You bet, waifu.
Okay. So here we are. To start with, I know these terminologies sound pretty familiar, look familiar to everybody, but generally tend to use the terms acidosis and acidemia interchangeably. But there is actually a slight difference between the two. Understanding this difference matters only really practically when we're dealing with mixed acid-base disorders. That is the one situation in which understanding the difference between acidosis and acidemia matters. Everybody on board with that? Any comments, questions along the way? Don't hesitate to bring it up or raise your hand. Now, again, we all know how vexing acidosis is. It is never a friendly subject. From medical school through residency, fellowship to practicing nephrology, pulmonary, critical care, acidosis is always a vexing issue for everybody. And for the patient as well, I might add. There's really, it is often taught in a box, like a pigeonhole. If you recollect medical school, you just cram and try to regurgitate without really understanding any connections or looking at the big picture of where acidosis fits in medicine. So often a lot of head scratching and head shaking when it comes to acidosis, right? Am I lying? Okay. So I tend to think of it as the bully, right? Bully wants you to avoid him, but you can't. You want to avoid the bully, but you can't, because it is everywhere you turn and relentlessly tormenting you. Those are all definitions that fit acidosis. So to confront that bully, you got to stop running. You got to turn and face the bully and ask the hard questions or throw a punch back if you have to. So the one question that got me really thinking about this whole scenario is, in medicine, why is there so much talk of acidosis relative to alkalosis? We do hear of alkalosis every now and then, but not nearly as much as we hear about acidosis. And so you go back and say, why so much acidosis? And that's what kind of enabled me to go back and deconstruct the whole thing. Where does acidosis come from? What produces it? And why is it so? Is the one way that I kind of eventually found my way around this vexing bully. So to start with, I will pose this question: which organ in the body is most important for excreting our acid load? And answers are there: lung, kidney, liver, spleen. Any takers for this? Any thoughts about that? All right. We will touch on this theme as we go along. So the key to understanding acidosis is really understanding food. Everybody can hear me, Theo? I hope I'm
Yes,
still.
we can hear.
So
And if you want to call out the residents, there's always Rex.
there's always Rex, right? Rex is default, exactly. All right, so key to understanding acidosis is to understand food and not orange juice, not vinegar. Often when you ask people about connection between food and acidosis, they're talking, oh, you know, citrus products, vinegar, acidic additives to food, but that's really not what we're talking about. We're talking about the real food that we eat. The three big food groups that we talk about: carbohydrates, proteins, and fats, right? That's where understanding acidosis lies. And why so? Because if we really think about it for a moment, you come to realize we knew it all along, but not stay in our consciousness so much that all our foods are really acids. All those three main food groups we eat are acids. And why do I say that? It is not what you see in the plate or what gets in your mouth. It is what the body takes from what you eat. And that doesn't happen until after digestion in the GI tract, which is just serving as a repository for the breakdown processes to occur. And it's only after you've broken the food down to the basic elements that those basic elements are picked up by your intestinal villi into your blood capillaries and into your bloodstream. That's when it gets in your body. So in that sense, if you look at what we obtain from eating fat, we all know the end products of fat digestion are fatty acids and triglycerols and chylomicrons, right? And fatty acids are really acids. The name says it. Even from high school chemistry, physics, we knew the name. Fatty acid is what we absorb from fats. But that aspect of it being an acid stays kind of lost to our consciousness. Excuse me. Thank you. Sorry about that. All right. So the fatty acid is what we take from fat digestion, right? Then we move on to proteins. And we all know again that the end products of all protein digestion are amino acids. And the amino acids that get inside our bloodstream. And again, we've known all along, they are called amino acids. So they are acids. Doesn't stay in our consciousness as such, but that's what it is. And if you look at the structure of any amino acid, it is a carboxylic group, the CHO group, and an amine group, which is usually NH2. That's the basic structure of any amino acid, but they are acids. So right there, you can see that all our fats, all our proteins enter our body as acids, right? Then we're left with the carbohydrates. We know the end products of carbohydrates are the monosaccharides, glucose, fructose, galactose. And again, you look at the structure, it's a CHO, basic unit. And no matter how complex the carbohydrate is, this is all that you're going to find in it: carbon, hydrogen, oxygen. It is just what bonds are formed, configuration of bonds and the elements in it that differ to make them different kinds of carbohydrate. But from the simple sugars to the bark of trees, lignin, cellulose, all of that. It's all this basic construct of carbon, hydrogen, oxygen that is woven into different directions and configurations and strengths to form the different kinds of carbohydrate, okay? So you would ask me, where is the acid in the monosaccharide? Because we absorb glucose, we absorb fructose, we absorb galactose. But I'll come back at you and say, we again know from those of us who are old enough to remember Prof. Woolhouse. Anybody here remember Prof. Woolhouse at Medical? Yeah, you guys are too young. So Prof. Woolhouse used to drill in us all the time. First thing that happens to all monosaccharides when they get into the body is to get broken down, right? Glucose gets broken down to pyruvic acid by glycolysis. That process of glycolysis breaks the glucose down into two pyruvic acid molecules, right? And it is really the pyruvic acid that is doing the work in the body. So in effect, although we absorb it as glucose, it is being converted to pyruvic acid for it to be used at all. So in that sense, we would agree that all our food groups end up as acids before or right after we take them into our body, right? So that's glycolysis that breaks it down to pyruvic acid. So the term acid comes there as well. All three major food groups are taken in the body as acids, all right? And these acids are our biofuels. Everything we do in the body depends on these things, building our body mass, flesh, bones, hair, cell membranes, providing energy. It's all through these biofuels, which are all acids. And the basic element in them all is this CHO, okay? So the major one for energy production, we all know, is the Krebs cycle. And the Krebs cycle utilizes monosaccharides as the substrate. And we said that the monosaccharide glucose first gets converted into pyruvic acid by glycolysis. And it's the pyruvic acid that goes inside the Krebs cycle, right? If you remember that. On the other hand, if you don't have enough monosaccharides around, your body will tend to burning other substances for energy. And fats can be burnt in the Krebs cycle as well. Again, you look at the structure of any fat, the basic elements are carbon, hydrogen, oxygen. The fatty acid is going to be broken down to basic elements of CHO, and that can get into the Krebs cycle as well. If monosaccharides, fats are not available, the body will tend to catabolizing its own mass, amino acids. It will break down the protein in your muscle and turn that into amino acids to be used for energy production, right? So the Krebs cycle preferentially uses glucose through pyruvic acid. That's the preferred fuel for our Krebs cycle. But in absence of that, it can use fats and it can use amino acids. So all of these elements can be burnt in the Krebs cycle for energy, okay? And again, I often hear people say that eating too much carbohydrate excess carbohydrates turn into fat. But if you really go back to biochemistry, we never really learned about carbohydrates turning into fat. The main storage substance of glucose is glycogen. Glycogen is not that much in the body. The total amount of glycogen that we generate and store is probably no more than half a kilo. Hello? Hello?
What's that? Hey, they've started. And I look at this unappetizing slide. Hey, what
We
a
okay?
shock. Is it on our page? Yeah.
Rex, are we on track?
I think they are muted now. Sorry.
So carbohydrates don't really turn into fat, but what happens is, since carbohydrates are the preferred fuel for the Krebs cycle, right? So long as you have a lot of it around, your fat does not get burnt in the Krebs cycle. It just sits and gets stored in adipose tissue. That's really the reason that eating too much carbohydrates makes you fat. It's just that you're not burning any of the fat that you eat every day. It just keeps stored in your adipose tissue and makes you fat. It's not so much that the carbs are getting turned into fat, okay? So if you don't have enough of this, or you limit how much carbohydrates you have in your diet, you will tend to burn in some fat and lose weight. As a matter of fact, those who know about the keto diet, this is the basis of the keto diet. By limiting the amount of carbohydrates you take in, your body is forced to burn more fat and maybe more amino acids, which is also the basis of DKA, by the way. The keto diet is just an artificial mild form of DKA, if you think about it, okay? Then, so here they are again, the Krebs cycle fuels are carbs, glucose, fructose, galactose, glycolysis, we get pyruvic acid, fats, fatty acids, and triglycerides, proteins, amino acids, carboxylic chain of this, that, and all of the carbohydrates eventually or essentially contain this. And Krebs cycle burns this down, and the exhaust that we get from the Krebs cycle, CO2 and water, we know that too. And you look at the structure of CO2 and water, it boils down to the same thing we've been talking about. It's carbon, hydrogen, oxygen, CO2, H2O. That's it. So we put in acid to the Krebs cycle, we derive our energy and NADP, whatever from it, and we are left back with the same elements that we put in. We're obeying the laws of what? Physics or chemistry. Matter cannot be destroyed or created. So we put this in, we have to get that out. And that is where the carbon dioxide and water come from. So ultimately, the food that we're eating all the time to burn for energy ends up producing carbon dioxide and water in our body constantly, right? And this CO2 and water, if you go back to high school chemistry, that combination is carbonic acid right there. So we're generating carbonic acid in our body all the time. And that carbonic acid needs to be eliminated, right? Now, so long as the Krebs cycle is functioning well, with no impediments, no inhibition, we get that CO2 and water from the process of complete combustion of the Krebs cycle. Oxygen is being delivered optimally. Every enzyme in the cycle is working right, and we burn to complete combustion, produce CO2 and water. If, on the other hand, something were to impair the function of the Krebs cycle, where it's not burning completely, such as in hypoxemic states, for example, you're not getting enough oxygen to the Krebs cycle, then you are not able to burn the pyruvic acid to complete combustion, and the pyruvic acid backs up, right? So you have more of pyruvic acid sitting around than you can burn it. You can't push it forward into the Krebs cycle. And that process ends up combining the, converting the pyruvic acid to lactic acid through lactic dehydrogenase. And that is where we get the lactic acidosis situation from. You get the lactic acidosis situation when the Krebs cycle is not functioning optimally. So I tend to think of that situation as producing soot, so to speak. If burning the fuel, if burning the furnace to complete combustion produces CO2 and water, then incomplete combustion or anaerobic combustion produces lactic acid, which is just like, your furnace or your fireplace is not burning well, and you end up generating a lot of soot, incomplete combustion. Okay, so so therefore, impaired pyruvic utilization tends to lead to lactic acidosis, which we'll come to later too. Now, so lactic acidosis tends to be classified as type A or type B. Type A lactic acidosis is what we're talking about here. Lack of oxygen is type A lactic acidosis. Hypoxia, decreased tissue perfusion from sepsis, from any kind of shock situation, right? Hypovolemic shock, hemorrhagic shock, septic shock will all produce that same situation of not delivering enough oxygen to your tissues for complete combustion of the Krebs cycle. Seizures. Again, in seizures, your muscles are overworking and generating a lot more pyruvic acid through anaerobic respiration than the Krebs cycle can handle. Krebs cycle is not sick in that case. Oxygen delivery is really not impaired, and you are producing much more pyruvic acid than the available oxygen, than the capacity of your Krebs cycle. And so you end up generating lactic acidosis in that situation. So vigorous exercise can do that. By the way, if you think about, again, seizures are not underestimated in the amount of contraction that occurs, because you talk about vigorous exercise and everybody can relate to that. But if you really pause and think about it, nobody can exercise as vigorously as someone who has a tonic-clonic seizure. You really think about it, right? Tonic-clonic seizures are the ultimate exercise anybody can undergo. It's involuntary, and it is so painful that nobody can willfully do it. So seizures are a pretty serious situation in which people can develop lactic acidosis very easily. Type B, lactic acidosis, you do not have any lack of oxygen per se. Oxygen is being delivered all right. It is just that something else is causing that Krebs cycle to not function well. Metformin, for example, some malignancies, some mitochondrial dysfunction, beta agonist, cyanide is the classic impairer of the Krebs cycle, and that's how it kills. But they produce type B lactic acidosis. All right. So we said earlier that assuming complete combustion, we produce CO2 and water as the end products of the Krebs cycle. You combine that, it becomes carbonic acid. Now, every cell in the body has carbonic anhydrase in it, cell membrane carbonic anhydrase. So as soon as this process occurs, carbonic anhydrase converts the carbonic acid immediately into one hydrogen ion and one bicarb ion, right? Because you have a high concentration of CO2 and water being generated constantly from the Krebs cycle in the cell. So the concentration gradient drives carbonic anhydrase forward into producing one hydrogen ion and one bicarb ion. And every living cell does that constantly. So by this process, we generate as humans about 15,000 millimoles of acid a day through this CO2 water conversion to carbonic acid, and then one hydrogen ion and bicarb. And the bicarbonate then turns around and buffers, holds the hydrogen ion in buffer. And that is how we transport the acid that we're producing in our living cells through the bloodstream to the lungs. Because we can't transport it as carbonic acid, our blood will be too acidic. And this process is what allows us to do that by carbonic anhydrase splitting the acid into hydrogen ion and bicarb. The bicarb then buffers the hydrogen ion. Hence that term that we hear so much about, the bicarbonate buffer system. This is the crux of it right there. And through this process, we are producing about 15 millimoles of acid a day. So how do we deal with all that acidity that we are producing from the food that we are eating? All right, and we said it, that carbonic anhydrase is the key at cellular level, drives this equation forward. So the bicarb then buffers the hydrogen ion to transport it in the blood at neutral pH and carries it that way until it gets to the lung, right? And that is the bicarbonate buffer system. And it is from this equation that the famous Henderson-Hasselbalch equation was derived, because it's all pertaining to hydrogen ions and carbon dioxide, which we are producing at cellular level through the Krebs cycle, okay? So then when this combination of hydrogen ions and bicarbonate reach the lungs, now the concentration of bicarbonate and hydrogen ions is much higher at alveolar level than CO2 and water, because we are constantly exhaling. We are exhaling CO2 and water, so we are keeping the concentration of those two gases at alveolar level at a minimum. And so relatively, the concentration of bicarb and hydrogen ion in the blood capillaries that are coming to the alveoli is much higher than the partial pressure or the concentration of CO2 and water vapor in the alveoli. So the same carbonic anhydrase is now driving the equation the opposite direction. So we're combining hydrogen ion, bicarb ion through carbonic acid, which then dissociates spontaneously into CO2 and water, and we puff it out, right? So that is how we are getting rid of all the acid we are producing from every cell in our body through the Krebs cycle. Eventually ends up in the lungs, and we puff it out as CO2 and water. And as I said, that is about 15,000 millimoles a day of acidity that we are getting rid of through the lungs. And this process is called the volatile or carboxylic acidity of the body. It's handled this way through the lung. Volatile because we can breathe it out. It's carbon dioxide, it's a gas. Water vapor is really a gas, and we blow it off that way. All right. So then if we say what is the most important excretory organ in the body, it has to be this. Because when it comes to the kidneys, although we all call the kidneys the excretory organ, they don't do nearly as much as the lungs do in eliminating acidity from the body. And we'll see that in a minute, okay? So any process that impairs your ability to breathe out CO2 will end up in CO2 retention, which is equivalent to respiratory acidosis. Okay, that is where respiratory acidosis comes from. Any process that impairs your ability to expire, to push out, to exhale that CO2 and water from the body will keep this equation stagnant. So it will go back, and then you end up retaining CO2 and in the body, and that is what is causing the acidosis. Okay. All right, and let's see. Then it's not all the food, it's not all of the food we eat that can be converted into this CO2 and water system to be shunted to the lungs to be blown off in our alveoli, because not all the stuff in our food is gaseous or can be converted to gases, right? We eat other things in addition to the main food components. We eat sulfides, we eat sulfates, nitrates, phosphates. Some amino acids even have sulfur groups in them. Those cannot be converted into gases, right? Drugs, other substances that we take into that are not food, they cannot be converted into gases. So the non-volatile or the non-carboxylic acidity that we generate in the body cannot be breathed out. On the other hand, they're all pretty much soluble in water, which means they dissolve in plasma, which means they can get carried through the kidneys and be filtered out, and we pee them out in the urine, okay? So the non-carboxylic acidity of component of our body ends up being thrown out or gotten rid of through the urine by the process of filtering or filtration in the kidneys. And that amount of acidity that we carry in our plasma to be peed out in the kidneys only amounts to about 100 millimoles a day, if that, compared to 15,000 for the volatile component we just talked about. So again, if you look at it this way, then the kidneys are nowhere as active in getting rid of our acidity as the lungs are. If you can't pee out this amount on daily basis, then you end up with metabolic acidosis, all right? If you can't breathe out the CO2 and water, you get respiratory acidosis. If you can't pee out the metabolic component fast enough, you get metabolic acidosis. So cycling back to that question from the beginning, clearly it seems to be the lungs are the most important. And even if you doubt this, just think about it practically. God forbid you can take somebody's kidneys out, both kidneys, remove them today, and do nothing. That patient isn't going to die today or tomorrow, maybe not the following day if you do nothing. It may take several days up to a week before that patient succumbs to lack of kidneys for excretion, right? On the other hand, if you can give somebody 100% oxygen, but remove the ability to excrete CO2 and water, which means remove the ability to ventilate. And that patient will not last but what, 10 minutes, 20 minutes, right? The most practical clinical example of this is the COPD patient that we all is drummed into our heads that don't give COPD patients too much oxygen because that would impair their respiratory drive. And what does that mean? They don't breathe as deeply as they should. And so they don't breathe out CO2 from their body and they end up in CO2 retention. And you can watch a COPD patient die in front of you. I mean, Theo, bear me out. It is amazing. So the fact that they are not able to breathe out the CO2 and water is what is going to kill them. You're giving them a lot of oxygen. Their PO2 is what, 110% or whatever. It's not the oxygen. It is the lack of excreting CO2 from the body that ends up causing the respiratory acidosis, which ends up causing the cardiac arrest, right? That is why in the mega codes, when they say consider your H's and T's, hydrogen ion is one of the first, and that is what that is coming from. Lack of excretion of CO2 ends up giving you severe respiratory acidosis, and that can cause cardiac arrest in no time at all. Okay. So once we got these basics of acidosis and where it is coming from, then how do we approach it practically or clinically? And again, I said it is vexing, confusing situation, but if you develop this systematic approach to any acid-based situation you encounter, it makes life a little less difficult. And the Henderson-Hasselbalch equation is key to all of what we do. That equation is put everywhere you see, but the practical implications of it are whenever you see an acid-based situation, first look for the primary change. The primary change is either the bicarb component of this equation or the PCO2 component. Those are the two things that we are measuring. We're not measuring the log of this or that, but we're measuring bicarb level, we're measuring PCO2. So you look for which of these is the primary change that is causing the acid-base disturbance, right? So if you see that the PCO2 is the major abnormality, which means it is high, then you say the patient is acidotic. On the other hand, if the PCO2 is the major change and it is low, the patient is alkalotic. If it is the bicarb, that is the primary change, then high bicarb means patient is alkalotic and low bicarb means patient is acidotic. So you see an acid-based problem, first determine whether it is an acidosis or an alkalosis. pH normal should be 7.4. You can stretch it and say 7.35 to 7.45 thereabout. So any pH that is less than 7.35, patient is acidotic. If it is higher than 7.45, patient is alkalotic. Okay, then you look for that primary change. Is it a primary change in PCO2 or is it a primary change in bicarb? Then once you determine which one it is, you determine whether you have enough compensation to account for what you are seeing. And there are several methods of doing that. One famous one we all know about is the Winters formula. There are others, but The Winters formula is used mainly to determine whether you have enough respiratory compensation of a metabolic acidosis. So to use the Winters formula effectively, you have to already know that you have a patient that has metabolic acidosis. Then you are using that formula to see whether you have developed, that patient has developed enough respiratory compensation for that. Okay. And again, if it is a primary respiratory acidosis, then the Winters formula does not work for that. And this is the formula represented here. And note that in the Winters formula, the key thing is you are going to find out the expected PCO2. What do you expect the PCO2 to be based on the numbers that you are seeing? And that is what you multiply your bicarb level by 1.5, add 8, plus or minus 2. All right. So that is that is what you are dealing with. You are using the absolute value of your bicarb level to determine the expected PCO2 absolute value. All right, in Winters formula. I'm stressing this because the other formulas work differently. These other formulas to determine compensation tend to work by using the change in one to determine the change in the other. So I tend to nickname them the delta compensation formula. If you have a metabolic acidosis, then you expect that the PCO2 would decrease by 1.25 for every milliequivalent per liter change in your bicarb level. So you are using the changes instead of the absolute values for this compensation formula. All right. So then we come to question number 2. You have these numbers here presented to you. What do you think the acid-base disorder of this patient is? pH is 7.34, PCO2 is 55, and the bicarb level is 30. Who wants to give this a shot? Rex? First of all, by going through the steps.
So the primary abnormality, we can see our PCO2 is very high, 55. And then we have acidemia for the pH of 7.34. So the primary pathology is likely a respiratory acidosis.
Primary respiratory acidosis, that is correct. Okay, so again, there is acidemia, pH 7.34. There is very high PCO2 and a compensatory rise in bicarb level. Normal bicarb should be about 24. This is 30. So it is a compensatory rise to try and compensate for that. So it is a primary compensated metabolic respiratory acidosis. Sorry. All right. Now, what about this one? pH is 7.65. What does that tell us?
There's alkalemia.
Okay. PCO2 is 30.
So that's low.
That is low. And the bicarb level is 35.
Yes, which is high.
Okay. So what is causing the disorder here?
Yeah, so it's most likely a metabolic alkalosis.
Yes.
Mixed, probably a mixed picture.
Exactly, it is mixed. It is a mixed alkalotic picture because even just looking at it, you can tell that this pH level is pretty high, right? 7.65 is pretty high pH, and the changes in this are relatively not that dramatic. So it is a situation in which you have two different types of alkalosis kind of augmenting each other to produce such a high level of alkalemia. So we can go back and do the compensation things, but you will find that this is a mixed alkalosis of metabolic alkalosis and respiratory alkalosis. Does that make sense? Somebody,
please.
somebody who,
Yes.
who can hazard a scenario in which you would have this kind of problem? Who can hazard a scenario? I would say even initial stages of aspirin overdose can produce a picture like this. Because initially in salicylate poisoning, they tend to hyperventilate, which is where the respiratory alkalosis may be coming from. Some patients may start vomiting and develop a contraction alkalosis, right? And this can be the initial phases of aspirin poisoning until the acidosis sets in. Acidosis tends to come later in salicylate poisoning, which tends to confuse the picture a lot. So initially, you may just have an alkalotic situation, but then over the next few hours, they can turn into a mixed picture where they will have both this and acidosis. And then as time goes on, as the salicylate is being metabolized further and releasing the toxic metabolite, they then turn into the frank acidosis, okay? So you can have that picture there. All right, this one here is showing us a pH of 7.4, PCO2 of 20. So 7.4, what we got?
So that's normal.
That's normal. So we don't have an acidemia, we don't have an acidosis, right?
Yeah.
Or alkalosis, sorry. Then the look at the PCO2. What is it?
That's low.
That is very low,
Yeah.
right? That's very low. And then look at the bicarb.
The bicarb is also very low.
Also very low, right?
So most likely a compensated metabolic acidosis.
I don't agree with that because you cannot overcompensate. That's the one thing, and you cannot fully compensate any acid-base disorder. So anytime you see a situation like this that is suggesting either overcompensation or full compensation, think of a mixed acid-base situation. It's a mixed acid-base situation, right? You have respiratory alkalosis because the PCO2 is so low. And on top of that, you have metabolic acidosis. So this is a mixed acid-base disorder of respiratory alkalosis and metabolic acidosis. And this is exactly the point I was driving up at earlier. This is a picture that they will present to you in somebody who has aspirin poisoning. It's a mixed acid-base situation. They have both the acidosis, metabolic, and then the alkalosis from the hyperventilating situation. And you may catch a patient at this time when there is no acidemia, no alkalosis. You see this and it looks normal to you. But this patient is sicker than a dog, right? Because they have severe respiratory alkalosis and severe metabolic acidosis. And the alkalosis and acidosis are countering each other to produce a falsely normal pH. So this is one of the situations I was telling you earlier in which understanding the difference between acidemia and acidosis matters, right? In this situation, the patient has acidosis, but no acidemia. That's the classic example where understanding that difference matters, okay? Most other situations, acidosis and alkalemia tend to seem to be equivalent and interchangeable. But when you're dealing with mixed acid-base disorders, then you got to be able to discern that difference, okay? Everybody okay with this so far? Any questions about this before we go on? All right, hearing none, we will proceed. So this is a mixed situation. Aspirin poisoning, classically will give you that, okay? Now, so then if you determine that your patient has a metabolic acidosis, you've done the compensations and realize that they are appropriate. It is pure metabolic acidosis, not mixed or anything. Then you go on to determine whether it is associated with an elevated anion gap or not. And you look for that anion gap, which time past we used to have to calculate, but these days almost every chemistry lab gives it to you on the panel right there. So you just look it up. Usually it's sitting under the bicarb level or CO2 level, and you see whether it's high or normal. The normal anion gap we say is about 8 to 10, right? But I want to bring this point across to you again, that anion gap concept is really an artificial creation. There is no disease condition called elevated anion gap. Any human being who is alive has to have 0 anion gap. If you measure all the positive ions in your body, all the negative ions in the body at any time t, so long as you're alive, it will be 0, because you have to have that electrochemical balance to be alive. So it's really not a disease condition, but something that we human beings created to allow us to help sort out the acidosis situation. And so human beings decided that since we are not measuring every chemical in the body, when we do the anion gap based on the chemicals that we measure normally, sodium, potassium, chloride, bicarb, and blah, 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 then the negative ions seem to be a little less than the positively charged ions. And they narrowed it down further and said, we don't even need to use all the components of the chemistry profile. We don't need to use all of the stuff that we measure on Chem 8 or Chem 10 or a basic metabolic panel. We just need 3 to do this thing with. So they selected potassium, chloride, and bicarb. And in measuring them, in a lot of people, they realized that the sodium, the sodium level by itself outweighs the sum of bicarb and chloride by about 8 to 10, right? That is where that normal, so to speak, anion gap level is coming from. The sum of bicarb and chloride just a little less than the level of sodium by itself. And usually the difference is about 8 to 10. That is the normal anion gap, okay? But if you do your test and the anion gap is recorded as high or you calculate it as high, then it is telling you that there are some additional anions present in the patient's body, in the patient's system, in the serum, in the blood that is being measured. Some extra anions have gotten in there, which we are not measuring, right? But they are causing an effect in the body. Since we have to have electrochemical neutrality, then they have to compete with the measured ions for the same size on the positively charged ions like sodium. So now, when you measure the available anions that we normally do, which are chloride and bicarb, then their total number seems to be even less because you have these other ghosts that have taken up sites on potassium and other sodium and other cations, but we are not measuring those anions. And so they tend to seem to be depressing the total number of chloride and bicarb. So it is like an apparent decrease in the number of bicarb and chloride, which is not real. But we use that to tell us that there must be some other anion in the system. And I just started calling them the ghost anions. They are there, they're causing an effect, but you can't see them. We're not measuring them, so we don't know, right? So if you have that situation, then you say, what can I do to find out what that extra or that ghost anion is? And so I say, then we got to go ghost busting, right? And what do you do to get your ghost busted? You look for a good tool. And the most famous ghost busting tool we know is the MADPARS, right? You go to the MADPARS and read out the stuff in the MADPARS. And that usually will end up giving you a clue as to what that ghost is. So all the constituents of the MADPARS are those ghosts that we're talking about, the ghost anions, are usually in the MADPARS. And so the MADPARS translates to this: methanol, uremia, DKA, paraldehyde, this, that, lactic acidosis, ethylene glycol, salicylates, right? Everybody knows that. Now, one thing I'll tell you is that uremia in this context is really not the clinical uremia. This is just a euphemism for renal failure. They don't have a way to fit kidney failure or renal failure or AKI in the MADPARS to make sense. So they just substituted uremia, but it is not true uremia. You don't have to be uremic. You just have to have kidney failure. You don't have to have severe kidney failure. It just mild elevation in creatinine sometimes can end up causing acidosis as well. Just as you don't have to have uremia to be hyperkalemic, right? So just take that with a pinch of salt when you see the U in the MADPARS. It's not true uremia. Just any level of kidney failure severe enough to impair your excretion of acids. That's what that's talking about. If you want to expand the MADPARS, there is another one called CAT MADPARS. You can add more stuff to it if you want. But again, these are all anions. If you look at them all the stuff here are anions which we normally don't measure when we do our chemistry profile. So they are going to remain hidden to you, but they cause effects enough to displace chloride and bicarb, so your gap gets elevated, okay? That's where that comes from. So these are the unmeasured anions. Usually methanol from the MADPARS turns into formates, which are the ones that are causing the problem. Ketoacidosis, we know about acetoacetate and beta hydroxybutyrate, Lactic acidosis is, lactic acid we talked about. Renal failure, the so-called uremia, usually from phosphates, sulfates, uric acid, things that we normally metabolize in the body, which I explained to you earlier, have to be peed out in our urine. And because the kidneys are not able to pee them out, their levels rise and give us a high anion gap metabolic acidosis. Ethylene glycol tends to produce oxalic acid, which is the culprit. Propylene glycol, lactic acid as well, toluene, hippuric acid. So these are some of the unmeasured anions that we get from those poisonous substances, okay? Now, you may have read somewhere that low albumin, because it is a negatively charged ion, low albumin can affect the anion gap. And this is a formula to correct for low albumin. If you're interested, you can look it up. All right. And then now, having said that, you notice one thing is when you look at the mud piles, it is all helter-skelter. You have M, which is methanol at the top, U, which is uremia, then D, you're talking DKA, and then it's all helter-skelter. And it's just a way for people to memorize. But you can actually deduce what is happening if you go systematically by understanding that everything in the mud piles is generated out of three basic mechanisms, right? The first mechanism is your body overproducing that ghost anion. The body is overproducing the ghost anion that goes in the mud piles, and that increased endogenous production comes from ketoacidosis and lactic acidosis, right? In both of those conditions, you are generating those acidic substances, extra anions from your own body. The next mechanism is decreased excretion, which is really kidney failure. We talked about that, all the acidic stuff that the kidneys have to get rid of. If they are not able to, then they build up in the body and can produce HAGMA, high anion gap metabolic acidosis. So already these two mechanisms account for DKA, lactic acidosis, and kidney failure in the mud piles. Then everything else there, you can go back and look at the constituents, has to do with exogenous intake of some anionic thing that you shouldn't take or you are taking too much of, right? That's everything else in the mud piles is from that. So if you have these three mechanisms in mind, then you don't even have to rely on the mud piles to figure out what is going on. And that's why I say you can throw the mud out of the pail, or you can throw the whole mud piles out the window if you understand these three mechanisms. Endogenous overproduction, decreased excretion, which is really kidney failure, and exogenous intake of something that you shouldn't take or something that you've taken too much of, right? Okay. Then once you determine that you have an elevated anion gap metabolic acidosis, you determine that you have HAGMA, elevated anion gap metabolic acidosis. Then you can go to this other confusing concept called the delta-delta. I don't know if you've come across it much, the delta gap and delta bicarb. Are you familiar with that, Rex?
Yes, we've had some, lectures on that before, but as you said, it's usually a confusing concept.
Very confusing. So what this is saying, you just pay attention to this and you won't be confused anymore. What this is saying is that you are saying you have an elevated anion gap metabolic acidosis. So take the difference of your elevated anion gap from normal. Normal gap should be about 10. And let's say you have a gap of 16, right? So the delta gap in that situation is 6. So you have an excess gap of 6, right? And take the change in your bicarb. So if you are acidotic, then your bicarb level should be low, right? And if all things are equal, the gap increases 1-for-1 with the decrease in bicarb. That's how it works. So for every 1 unit increase in anion gap, let's say lactic acidosis, for example, let's use that. Again, lactic acidosis is one in which you can work this thing yourself to make it make sense to you. If you have a lactate level of 6 and a gap of 16 and a bicarb level of 18, it is right there in front of you. That is lactic acidosis, right? It's your lactate level. Remember, it's part of it's one component of the MAD paths. Endogenous overproduction of lactic acid. So your excess level that you are measuring in the body is high as 6. If you take that 6 and subtract it from the gap of 16, your gap will become normal. Because then the lactic acid is what is accounting for that elevation in your gap. And on the other hand, if you take that bicarb level of 18 and add 6 to it, you get 24, which brings your bicarb back to normal, right? So they're saying that for every increase in the gap, you must have a commensurate decrease in the bicarb level. That's what this gap thing is talking about. All right, so the delta gap should be equal to the delta bicarb. Increase in gap, decrease in bicarb should be the same, so the ratio will be 1-to-1. Some books that or scripts that want to confuse you more would subtract the bicarb gap from the delta gap and give you 0. So pay attention to whichever text you are reading. Most of them tend to do it as a ratio, 1 over the other. So it should be 1-to-1. And if you have that situation, then you can say that the patient has uncomplicated high anion gap metabolic acidosis. All right. If on the other hand, you do the delta and the gap, the change in delta seems to be less than the change in bicarb, right? So the change in gap, let's say now you have 14, anion gap 14, which means you've changed by 4. And yet your bicarb level is still 18, right? Then your gap ratio will be less than 1, right? You have a smaller numerator and a bigger denominator. So your ratio will be less than 1. And what is that telling you? The way to understand is to think that you have relatively few ghosts, right? Your gap is only 4. So it means that the ghost anion that is causing the problem is only 4. And yet those 4 ghosts seem to be producing more acidosis than they should be doing. They're more potent, so to speak, than their numbers should suggest, right? You have 4 ghosts, and yet they are producing the acidotic effect of 6 ghosts. Does that make sense? So you are saying that there is more acidosis than there are ghosts. So you call them macho ghosts. These are macho ghosts. few of them are able to produce very severe acidosis. And when you get that situation, then you tell yourself, there must be another acidosis producing situation in that patient, cause these numbers, this disparity in the numbers, right? So that patient must have either a coexisting RTA, renal tubular acidosis, which is normally a non-elevated anion gap metabolic acidosis. They don't produce anion gaps, RTAs. So you can have an RTA in addition to the elevated anion gap metabolic acidosis I have. So think about situations like diarrhea, for example, or Fanconi syndrome could be coexisting with whatever metabolic lactic acidosis we have, right? So we have lactic acidosis, which will produce the elevated anion gap metabolic acidosis. But in addition to that, patient is having diarrhea. And that diarrhea is creating the effect of an RTA. And so there is more severe acidosis than the ghosts or the change in anion gap can account for. That's what that is telling you. If the gap is less than 1, think an additional acidosis producing condition in the patient, or think that there could be a rapid elimination of the ghost. This can happen in DKA too, because if the kidneys are working well, at least in the beginning, the acetoacetate that you are producing as part of DKA is being eliminated by the kidneys as well. So in effect, the acetoacetate itself number may be lower than the acidosis would suggest to you. So rapid elimination of the ghost can make the level of the ghost seem to be less than the amount of acidosis is producing. So coexisting RTA, diarrhea, Fanconi, DKA, tolerance, glue sniffing can present like that. That is what the decreased delta gap means. Now, if on the other hand, you do a delta and the ratio is greater than 1, then you think to yourself that there are more ghosts than they are producing acidosis, because now you have a gap of, let's say, 8, right? A delta gap of 8. So it means that the anion gap in that patient is 18, delta gap of 8. Then you should expect that your bicarb level should decrease to about 14, because you take 8 from 24, what are you getting down to? 16, I'm sorry. Your delta bicarb should be about 16. But then you do the math and you see that although you have a change in gap of 8, right? You are only producing acidosis to maybe about a bicarb level of 18, for example, or let's just say even 20. So it seems that all of these ghosts, 8 extra ghosts in the system, are only producing relatively little acidosis, the equivalent of 4 ghosts acidosis worth being produced by 8 ghosts. So I started thinking of those as, oh, these are wimpy ghosts, right? A lot of them, but they're only producing a little bit of acidosis. So they are wimpy ghosts, as opposed to the first situation where we call them macho ghosts. These are wimpy ghosts. And if you have that situation, then you say, oh, there must be some other condition in the body which is working against these ghosts to make them seem wimpy, right? So there must be a counterbalancing alkalosis to make them seem so wimpy. That's what this high ratio tells you. So usually when the ratio is higher than 1, or if you're using the subtraction thing, if the subtraction is greater than than 1, which is positive numbers, then you say that there must be a coexisting metabolic alkalosis, which is countering the ghosts, right? Or there could be a situation in which kidney dysfunction may prevent the excretion of the ghosts. So there seem to be a lot of them around, but not really causing too much acidosis. You can think of that too. But usually it has to mean that there is some coexisting alkalosis that is confounding the picture, okay? Chronic respiratory alkalosis can also do that. So delta gap greater than 1, additional condition of alkalosis, which seems to be dampening the effect of the ghost. On the other hand, ratio less than 1 should be an additional acidosis, which seems to be potentiating the effect of the few ghosts that are around. That makes sense, Rex?
Yes, yes.
Does that make it a little less confusing for you?
Yeah, a little less confusing.
Okay, you read over that a little bit and you see that's what that is about. If you think about it as so many of these should produce exactly the same amount in acidosis, but one situation I have too many, which means the delta gap is much more than the change in bicarb, then some alkalosis is present. If on the other hand, only very few, relatively small change in the delta gap, producing much more acidosis than it should, and a coexisting acidotic problem, usually non-anion gap, like RTAs, diarrhea, Fanconi, and things like that, okay? All right, move on. On the other hand, you determine you have metabolic acidosis. You look at the anion gap, and it looks normal. So you have a situation in which you don't have any ghosts in the system, but you have an acidosis anyway on your hands. So that is the situation of normal anion gap metabolic acidosis, usually given the abbreviation NAGMA. No ghost anion is present. It's just that you have a high hydrogen ion concentration for some reason. And the things that can produce that are usually the RTAs, renal tubular acidosis, type 2, which is the proximal tubule dysfunction, mostly from Fanconi syndrome. They call type 2 because that was the second type of RTA to be elucidated, although it is before the distal tubule. It's proximal tubule dysfunction. They cannot reabsorb bicarb, or anything else, right? Fanconi syndrome, they tend to lose all the nutrients in the plasma from the kidneys. They can't reabsorb electrolytes, they can't reabsorb glucose, it's just general proximal tubule dysfunction. And the proximal tubule is where most of bicarb is reabsorbed. So they lose bicarb in addition to all the other stuff, and they end up being acidotic because losing bicarb essentially means gaining hydrogen ion. You have to have a one-to-one relationship between the bicarb and the hydrogen ion. So proximal tubule dysfunction type 2, RTA, okay? Then the distal convoluted tubule dysfunction can produce type 1, RTA, renal tubular acidosis, which was the first one to be encountered or to be sorted out, discovered. So this situation is where the distal tubule is not able to secrete hydrogen ions into the urine. It's different from renal failure. Their creatinine may be normal. They're checking out, metabolic waste products easy and well. So normal GFR, normal creatinine, normal urine output, but the proximal tubules for some reason cannot secrete hydrogen ions into the urine to make the urine acidic. So they retain the hydrogen ions in the body. So then the pH of the blood or the body drops. But there's no ghost anion present that is doing it. It's just a primary dysfunction of the tubule to do its job of secreting hydrogen ions into the urine. And toluene, which produces hippuric acid, can also present like that. It's a distal tubule dysfunction specific to hydrogen ion secretion. Okay, that's type 1 RTA. And type 4, there used to be a type 3, but they found out that it's type 3 is either some combination of this and that, or they got rid of that. So now we have type 1, type 2, and type 4. Type 4, just think of hypoaldosteronism. This occurs in the collecting tubules. Remember, type 2 is proximal tubule dysfunction. Type 1 is distal convoluted tubule dysfunction. And type 2 tends to result from dysfunction in the collecting tubule. So we're going down further and further in the kidney. And it happens at the site of aldosterone action. So it can come from either hypoaldosteronism itself or anything that impairs the aldosterone receptor or the function of the ENaC or whatever can cause that situation. That's why it's called type 4 RTA, collecting tubule, and it can be hypoaldosteronism. And the main effect of that tends to be more hyperkalemia rather than acidosis per se. When they ask about this on the boards, they tend to present patients to you that would seem to be hyperkalemic, and you take your mind off from RTAs to treatment of hyperkalemia, but they're actually asking you questions about, type 4 RTA. So be aware of that. They'll present a situation in which potassium may be like 6.6, 6.8, which catches your eye, but the pH may be recorded as 7.34, 7.33, not as eye-catching as that potassium of 6.8. So they divert your attention to hyperkalemia and swerve you there. So be aware of that. They tend to ask questions about this quite a bit. Okay, any situation that produces a hypoaldosteronism state, even diabetes mellitus can do it, because diabetes tends to cause a hyporenin state, right? Diabetes affects the kidney. Kidneys can't produce enough renin. So if you don't produce enough renin, you don't produce enough stimulation of the adrenals to produce aldosterone. So you get into a hypoaldosteronic state. You can develop RTA type 4 from that. All right. And the next thing other than the RTAs is diarrhea. So if you're talking about normal anion gap metabolic acidosis, you think RTAs and diarrhea. And I may have said it before, the first time I encountered this, I kind of wondered. I said, diarrhea, RTAs seem to be such a, dignified term and a nicely described condition. And then they're in the same group with diarrhea. And I felt a little disappointed in that grouping. But then with time, you come to realize that diarrhea is really just the GI version of RTA type 2, right? RTA type 2, you can't reabsorb anything in your proximal kidney tubule. You lose it all in your pee. Diarrhea It's, GI malabsorption. So you lose stuff in the stool. So both of them tend to end up with RTA type situation, okay? So diarrhea and Fanconi syndrome are very similar, both by bicarb loss, okay? So those are the mechanisms by which acidosis is produced. I believe we've gone way beyond time, right? What we are left with are the clinical manifestations and treatment. Not much to talk about there. So the main focus of this lecture was to get people to understand the origins of acidosis and the various classifications and how you can sort out trying to determine the cause when you encounter it in a patient. So we can end it there. And if there are questions, be welcome to ask. Any questions, starting from Rex?
No, Dr. Waifu, I think it went down well.
Wonderful.
Wifo, if you could share your PowerPoints with me, then I'll share it with Rex and his team.
Oh, surely.
Yeah.
Got it.
Okay, I don't see any questions in the chat.
Nice.
Does anybody else have a question? If not, then I think we are finishing off the ABGs to next week with Dr. Pipim.
Wonderful.
And then after that, we will do, so this lecture is very helpful. And then we would, for the residents, the week after that, we will do safety measures in the ICU. If you have any specific topics that you would like, I was going by my critical care lecture series, but if you have any specific topic you would like us to have, you can send it through Rex as well. If it's neuro ICU, cardiac ICU, whichever one, I'll find a lecture to give it.
All right.
Okay. All righty.
One other thing we can do is fluid and electrolyte. I don't know if we've done that before, have we?
Fluid and electrolytes.
All right.
I don't think so. Wifo, if you give me your time, I can put you on the schedule and then we can do fluid and electrolytes.
Wonderful. Thank you.
Thank you very much. Thank you very much.
You bet.
And for those who don't know Wifo is Dr. Foley Sechima, but we all call him Wifo. He's an interventional nephrologist in Wifo, you're in North Carolina, right?
You got it.
Yes. Okay. Thank you so much.
Thank you very much.
All righty. Take care.
Bye now.
Bye.